Picture this. One moment you're seeing clearly, the next, it's just darkness. Like someone literally flipped a switch off.
Yeah, that's a scary thought.
It really is. And today, we're diving into a potential way to fight back against that kind of sudden vision loss, specifically in a very critical eye condition.
Welcome, the learner. This exploration into hyperbaric oxygen therapy, or HBO, is really for you, someone who wants to get under the hood of complex medical topics, without getting totally lost in jargon. You've shared some really interesting sources on this therapy, and today we're focusing it right down onto a very specific use case in eye health.
Exactly. Today, the spotlight is on central retinal artery occlusion, or CRAO.
Right.
Think of it like a sudden, very serious blockage, almost like a stroke, but in the main blood vessel feeding your retina.
The retina being that light-sensitive tissue right at the back of your eye, crucial for sight.
Absolutely.
And we've got a good set of materials here, some handbooks on hyperbaric medicine, research articles looking into how it works, its applications.
Our mission really is to pull out the key insights on using this hyperbaric oxygen therapy specifically for CRAO.
Let's do it.
Okay, so let's get right to it then. Central retinal artery occlusion, CRAO. Can you break that down a bit more? Why is it so critical?
Well, like you said, it's a blockage. The main artery supplying blood and crucially oxygen to the retina gets blocked suddenly.
Okay.
And the retina is incredibly hungry for oxygen. It uses a lot. So when that supply is cut off, well, the tissue starts to suffer damage almost immediately.
Which leads to that sudden, often severe vision loss we talked about.
Exactly. It's a true medical emergency. Time is absolutely of the essence.
Right. That paints a pretty stark picture. So given this urgent threat, let's bring in hyperbaric oxygen therapy. What's the basic idea? How does it work?
So in simple terms, HBO involves breathing 100% pure oxygen.
Okay, not the roughly 21% oxygen in normal air.
No, pure oxygen. And crucially, you do this inside a special chamber where the air pressure is increased significantly, usually maybe 2 to 3 times normal atmospheric pressure.
Higher pressure. What does that actually do? What's the benefit?
Well, under normal pressure, most oxygen in your blood is carried by hemoglobin inside your red blood cells. There's only so much hemoglobin can hold.
Right, it gets saturated.
It gets saturated. But when you increase the pressure while breathing pure oxygen, you force much, much more oxygen to dissolve directly into the plasma, the liquid part of the blood.
Ah, okay. So it's not just about the red blood cells anymore.
Not primarily. No, you get this huge increase in oxygen just dissolved in the fluid itself. One of the handbooks, from '96 actually, points out this dissolved oxygen is what gets exchanged with the tissues first under these conditions.
Okay, I think I see where this is going for CRAO. If the main artery is blocked, the red blood cells physically can't get through.
Exactly.
But maybe this oxygen-rich plasma, this liquid, can sort of seep through or around the blockage, or perhaps use tiny alternative pathways.
That's precisely the hope. That's the rationale. The extra dissolved oxygen might, just might, be able to reach those starving retinal cells, even with the main highway blocked.
Keeping them alive, or at least reducing the damage.
Reducing the damage, buying time, potentially preserving some vision. That's the goal. We want to get enough oxygen there to tide the cells over.
And is this just a theory, or has it been looked at?
Oh, it's definitely been looked at. One of the textbooks we have mentions a review from 2009, looking back at, I think, 20 years of experience using HBO for CRAO. So there's certainly been clinical interest in investigation for quite some time.
Okay, so that primary mechanism is getting more oxygen dissolved in the plasma to bypass the blockage. Are there other ways HBO might, theoretically, help in this situation, even if they aren't specific to CRAO?
Yes, it's worth thinking about the other general effects of HBO, but, with the caveat that we're kind of extrapolating here from how it works elsewhere.
Understood. So what are these potential side benefits, so to speak?
Well, first, just reinforcing that main point, the sheer amount of extra oxygen. One of the physiology texts mentions that at around, say, 2.4 times normal pressure, the oxygen levels in plasma and tissues can jump tenfold.
Tenfold? Wow. Compared to just breathing normal air.
Compared to the small increase you get in hemoglobin-carried oxygen, it creates a much bigger push, a gradient, for oxygen to move into those oxygen-deprived or ischemic tissue.
Okay, that's significant. What else?
Another effect HBO can have is reducing edema, which is, swelling.
Right.
It does this partly by causing some vasoconstriction tightening of blood vessels in tissues that aren't oxygen-starved. Now, CRAO isn't primarily about swelling, but if secondary swelling develops in the retina,
That can make things even worse, restricting any remaining flow.
Exactly. So reducing any potential swelling could be helpful.
Makes sense. Anything else?
There's also evidence mentioned in a more recent source from 2020 that HBO can have anti-inflammatory effects.
Right.
It seems to kind of dial down the production of certain inflammatory signals, these molecules called cytokines.
And inflammation could add insult to injury in a blocked artery situation.
It certainly could. Inflammation might worsen the damage to the delicate retinal tissue, so tamping that down could be another plus.
So potentially less swelling, less inflammation.
And one more thing, improved microcirculation. Several sources mention that HBO seems to help blood flow in the tiniest blood vessels, the capillaries, within ischemic tissues.
So if there is some residual blood flow or tiny collateral vessels trying to compensate.
HBO might help optimize that flow, getting whatever little blood is moving around to work more effectively.
Okay, those all sound like potentially useful effects on top of the main oxygen delivery boost.
Yeah.
But this sounds almost too good to be true for such a devastating condition. There must be catches, right?
Yeah.
Big consideration.
Oh, absolutely. Several huge ones. The first, and maybe the biggest hurdle, is time.
We keep coming back to that.
We have to. The retina is incredibly sensitive to oxygen loss. Brain tissue is sensitive, but retinal tissue might be even more so. We're talking minutes, potentially?
So if HBO is going to work, you need to get the patient into that chamber incredibly fast.
Extremely fast, almost certainly within hours, and likely the sooner the better. There's probably a very, very narrow window where it could make a real difference before the damage becomes permanent.
That's a massive logistical challenge in itself.
It really is. Think about recognizing the symptoms, getting to an emergency room, getting the diagnosis, then getting transferred and treated in a hyperbaric facility.
Yeah, the clock is ticking loudly the whole time. What else?
Well, HBO isn't without risks itself. Breathing pure oxygen, especially under pressure, can be toxic.
Oxygen toxicity.
Yes. The handbooks mention potential issues for both the lungs and the central nervous system. Things like seizures are possible, although generally considered rare at the pressures typically used, say, below 3 atmospheres. But it's a known risk that needs careful management.
So it's a balancing act.
Yeah.
The potential benefit versus the potential harm of the treatment itself.
Always. And another major point is, well, the evidence just isn't definitive yet for CRAO.
Despite that 20-year review you mentioned.
Right. While there's interest in ongoing study, the sources we looked at don't point to, like, a strong consensus or widely accepted guidelines saying, yes, use HBO for CRAO, here's exactly how. It's not standard of care everywhere.
So it's still considered somewhat experimental, or at least not universally adopted for this specific condition.
That seems a fair way to put it, based on these materials. It's still under investigation.
Do we even know what kind of treatment protocol might be used? Like how much pressure for how long?
Well, we can get a general idea. One source mentions typical protocols for things like, say, non-healing wounds often involve pressures around 2.0 to 2.4 atmospheres with treatment times of maybe 90 to 120 minutes per session.
Right.
But again, that's a general range. These sources don't lay out a specific validated protocol just for CRAO. That probably still needs more research.
Okay. So let's try and pull this all together. We've covered quite a bit. What are the main takeaways for you, the learner?
I think the key thing is this. Hyperbaric oxygen therapy makes logical sense for CRAO. Increased oxygen in the plasma could theoretically help bypass the blockage.
Right. The rationale is there.
The rationale is there,
Okay.
and it might have other helpful effects like reducing swelling or inflammation, but, and these are big buts, the time window is incredibly short. Getting treatment started quickly enough is a major, major challenge. And as of now, based on these sources, there isn't definitive, widespread agreement or rock-solid evidence that it's a standard, proven treatment for this specific emergency.
So for you, the learner, this deep dive really highlights that fascinating, sometimes frustrating gap between a potential therapy that makes sense physiologically and proving it works reliably in the real world, especially for urgent conditions.
Exactly. It underscores why we need good clinical trials, even for emergencies. Understanding the how is one thing, proving the if and when is another.
Which brings us to a final thought, something for you to mull over.
Given how devastating sudden blindness from CRAO is, and given that the idea of forcing more oxygen to the retina seems logical, what do you think are the absolute biggest hurdles? Not just the timing, but maybe in designing the research or getting medical systems coordinated to figure out once and for all if and how HBO should be used in these critical eye emergencies.
Yeah, thinking about the practicalities, how do you study something effectively when every minute counts and the condition itself is, thankfully, relatively rare?
It's a tough nut to crack. something to think about.